your side of town because where we are, it is quite it's quite cold. Yeah. We are now sitting at 406.48. So let's just maybe allow them a few more minutes, then we can start. For those of you that are joining, welcome, welcome, welcome. Thank you so much. And Alasdair, the other day it was very hot, your area. How is it today?
Casey, good things never last forever, and true to form, it feels very cold and damp here today. So I've got nothing that's worth reporting other than it's UK weather as usual here. So nothing like what Kobus has in the Western Cape, or probably you have in Joburg, because you get the sun shining every day at this time of year.
Yeah, I see. Well, I think let's start with the meeting already. I have people that are registered on our Zoom at the moment who have joined 436. We are live on Facebook. So welcome to everyone that has joined us. My name is Makhubele. I will introduce you the speaker and the fellow panelists later. If you are a member of the profession and you intend to get CEU points, please ensure you are not watching on Facebook, but that you are watching on Zoom. How it works is you just have to be on Zoom throughout this time, and you will get your CEU points without having to write an exam or anything like that. We download the list, and because you had registered to join, we've got your details, and then we will send you an email or a letter just confirming that you've attended the Zoom. It won't be your CPD certificate. That CPD certificate should be available to members in the next, let's say by the end of, or middle to the end of July. We are migrating into a new system, a beautiful, beautiful system. All of you are going to like it. So you're going to get your CEU points. Yeah, and then what I think you should be aware is this meeting is being hosted basically by SADA and Dental Protection. They are providing all the work that you see today. I do not want to take more time. In terms of the panelists, the three people that you are looking at will be your panelists. Myself, I'll be moderating or chairing. I've got Dr. Alasdair, you know him. I said he's a South African man, and we're just counting a few more months. He's gonna come back to home. You're most welcome, Alasdair. And our speaker today is none other than Dr. Barnard, Dr. Kobus Barnard. You know him as the mediator in South Africa, and he's been doing a brilliant job behind the scenes and actually assisting in terms of all the cases. So we would thank him for joining us tonight. Dr. Barnard, over to you.
Good evening, colleagues, friends across South Africa and in the UK. Thank you for joining us for this third and final webinar brought to you by SADA and Dental Protection. Thank you for giving up your time after a long and hard work day and whatever you normally do on a Tuesday evening at 8 o'clock. You know, while I was preparing these slides last week, I was listening to our Finance Minister, Tito Mboweni, deliver his supplementary budget. And I just realized, you know, we are all desperate for some good news. And I'm pleased to inform you that I've got some good news for you in my presentation tonight. So my topic for tonight is called Back to Basics. It was supposed to be my topic for the SADA Roadshow in May this year, which we know by now never happened because of the current situation. And although I'd much rather present the topic to you in person, I'm just grateful for the opportunity to present it digitally this evening, which I understand is the new normal. And I just want to thank everyone involved for making this possible, especially Casey and his team, Marlies van der Linde from SADA and Stacey, Mac from MPS. You know, whenever these people are involved in something, you just know it'll be a big success. Okay, so back to basics. So how often have we heard the term back to basics? When things are not going well, or not going as planned, we go back to basics. This whole concept of back to basics is trending in politics, business, and sport at the moment. You know, in sport, when a sports person don't perform, he goes back to the basics. When businesses don't make a profit, they go back to the basics. And when political parties lose votes, they go back to the basics. You know, for us as a profession of dentistry, these are undoubtedly challenging times. The number of complaints against dentists has increased the last few years, and so has the cost of our professional indemnity. So maybe it's time for us as a profession to go back to the basics. So these, let's just get my slideshow running here. So these are just some new, recent newspaper headlines highlighting the principle of back to basics. So the ANC, our ruling party, going back to basics following their low Gauteng voting score. Joe Root, the England cricket captain, going back to basics to discover his best form and, of course, win the Cricket World Cup last year. And a Harvard Business Review saying that you need to get back to the basics to grow your business. But what exactly does it mean to get back to basics? So I'm quite a Wikipedia fan. So if you ask Wikipedia what this means, it will tell you that you need to stress simplicity. You need to adhere to fundamental principles. You need to not to be too concerned with complicated details. So for me, the profession seems to focus too much on advanced treatment options like digital dentistry, laser treatment, active aligner therapy, which is all good and well, don't understand me wrong, provided that you do the basics right. But what I see in my role as mediator is that dentists fail to do the basics right, and how these preventable situations inevitably lead to patient complaints and contribute to the rising costs of indemnity. So what is the basics of being a good, caring, competent, ethical dentist? Well, first of all, of course, the clinical principles and the skills we've learned at university, postgraduately and through continued CPD. But it's also important to know what is expected from us by the regulator, the Health Professional Council. You know, every sport has rules, every game has rules, and every profession has rules. And if you want to play the game, you need to know the rules. So as healthcare practitioners, we are expected to subscribe to certain rules of conduct. And to this end, the Health Professional Council has developed a set of rules against which complaints of misconduct will be evaluated. These rules offer guidance and direction, but it also makes it possible for the Health Professional Council to impose sanctions against transgressors. These rules are published in the form of 17 booklets and downloadable from the website of the Health Professional Council for us, but for our patients as well. And I think we should know these rules if we want to play the game of dentistry. I want to show you an interesting study that was published in the South African Dental Journal in July last year. The aim of this study was to analyze the nature and the outcome of malpractice complaints against oral healthcare practitioners reported to the Health Professional Council. So it's a 10-year period, and I just want to highlight the most interesting findings of the study. So in the 10 years, a total of 26,958 complaints were reported to the Health Professional Council. A quick bit of maths will tell you it's about 225 per month, which is quite a bit. The study indicated a gradual rise in the number of complaints against us in South Africa, but also globally. And possible reasons for that was that patients are getting more empowered and knowledgeable through the internet, of course, the reduction in dental benefits from third-party funders and medical aids, and the increasing operational costs of running a practice together with a shrinking market. But where this study gets really interesting is that 77.8% of the complaints processed by the Health Professional Council falls into the non-clinical category, which is mostly fraud and unprofessionalism. So under unprofessionalism, you will find a lack of informed consent, poor record keeping, poor infection control, basically not following the rules of the game, which leaves only 22.2% in the clinical malpractice category, where the dentists fail to achieve their therapeutic goals or the standards set by the profession. These are surprising figures, but it very much agrees with my own findings as a dental mediator at SADA the last 6 years, where only 33% of the complaints received by SADA falls into the clinical category. And this, my colleagues, is the first good news I have for you tonight, because what this tells me is that the rise in the number of complaints against dentists does not necessarily reflect a deterioration in the standards, in the clinical standards, but rather a failure to follow the rules of the game. So the recommendations from the study is that there should be an emphasis on ethics and practice management in CPD events.
Alasdair, are we okay? I think we have lost the connection to Dr. Barnard. We do apologize. Let's try and see if we can reconnect with him once more. And we have seen that Dr. Anonymous, we have lost connectivity. We will try and carry on. Maybe, Alasdair, are you able to carry on in the meantime?
Yes, I mean, I'm not going to carry on with Kobus's presentation, but I can certainly just add my thoughts to the reasons why patients are complaining. And Kobus here is talking about failure to play the game by not knowing the rules. And I think we've got to be careful about how we interpret playing the game, because it suggests that you maybe want to bend the rules or something like that. So playing the game here is understanding your ethical boundaries and making sure that where there is an opportunity to take a wider interpretation of what the ethical rules say, you have to make sure that you don't step over the line here. So there is a bit of flex in the ethical rules, but the key here is to make sure that you don't step over the line onto the other side where you find yourself at risk of being charged with unprofessional conduct. So that would be my first take from the first part of his talk, is that he is saying that there's not been a deterioration in clinical standards. More so, there's been an increase in expectation from patients about what they expect from their dentist. And it may be in relation to information, it may be in relation to outcomes, it may be in relation to the cost of treatment, but all those things matter to patients. And what I've been doing is I've been putting together an article for Riskwise this week. And my thoughts are very much along the lines of how patients are now seeing their dentist, and they're not seeing their dentist as a healthcare practitioner necessarily. They're using their consumer mindset to approach dentists, and maybe they will approach one or two dentists until they find a treatment plan or a dentist they like for the same condition, or more appropriately, a price that they like for the same condition. So, market forces are driving the behavior of our patients, and we just need to be aware that their expectations about what the service looks like nowadays have changed. And goodness me, I mean, it would be interesting to hear, if we get Kobus back online, what some of the COVID-related complaints are. But I mean, there will be an expectation that patients can still access care when it's possibly not safe to do so. and there will be an expectation that the dentist will consume all the PPE costs as well, and they won't be passed on to the patient. So those are my initial thoughts, Casey, and I wonder if there are any questions coming in live that we can pick up.
At this stage, no, we don't have questions.
Is there anything that you would want to ask me, Casey?
Yeah, I just wanted to give this feedback that Dr. Barnard says his internet has become unstable. I do believe the Cape Town area is struggling this today, but he's going to try and join. Maybe what you could do, Alasdair, well, maybe I see a question before I ask you from Dr. Bravishiralal. When playing the game, there are different players involved. Apart from the clinician, what may we expect from a patient?
So within the HPCSA ethical guidelines, there are some guidelines about duties of the doctor and duties of the patient as well. So there are some conditions about what we would expect in the way our patients behave when they receive dental care from us. And a lot of this is built around trust. A lot of this is built around patients honouring their contract. And essentially, when you agree to provide treatment, then you have a contract with your patient. And the patient has obligations as well as you do to fulfill the terms of that contract. So it might be worth having a look on the HPCSA website to have a look at what the duties of the patient are, because there are certainly duties for the profession, but there are expectations about the patients as well, what their expectations around their behaviour. Things like when you make them an appointment, they'll turn up on time. If they're not going to make it, they will let you know in a timely fashion that they can't make your appointment. Just things like that. It's about consideration. It's reciprocal consideration for the interests of the dentist and the interests of the patient.
Maybe at this stage, you could make a delineation between the work that Dr. Barnard does, which is mediation, and the process that your legal team does to differentiate what is his actual role versus the legal team, because sometimes I think people conflate that.
Okay, so the role of the mediator is to negotiate between the dentist and the patient where there is a complaint, to put the patient's expected outcome to the dentist, and for the dentist to put their version of events forward to the mediator. And the idea of the mediator is not to comment on the clinical treatment, but it's just to say, look, this dentist says there was nothing wrong with your treatment and it was what was agreed, and they see no reason to give you back your money. And the patient is saying, well, that's all very well and good, but I wasn't told about the extra 10,000 Rand, and had I known it was going to cost that much, I might have postponed the treatment, gone somewhere else, or taken a cheaper form of treatment. So it's about a negotiation between the dentist and the patient. So nobody's looking at the clinical treatment and making a decision about whether it's of an acceptable standard or a negligent standard. It's up to the dentist to recognise themselves whether their treatment's acceptable. But it's all about a negotiation between two people who may be miles apart at the start and find some common ground for agreeing the way forward. And usually it involves a degree of compromise on both sides, but there are situations where Kobus will have to say to the patient, look, your complaint is out of order, and I don't think there is any basis for this. If you don't agree with my mediation, then there are a number of avenues open for you to proceed to. So most patients don't want to go to an attorney. They want their problem sorted out with the practice or through mediation. And what mediation does is it provides this extra resource so that extra resource so that you don't need to go to an attorney, and it keeps it sort of very much non-adversarial. Whereas when we get involved, things are a little bit more serious. And there may be situations where Dr. Barnard is doing a mediation and he says to the dentist, so look, maybe you should speak to your indemnity organisation first before you come back to me to make a proposal, because it could be that there is a clear need to give the patient a refund or to actually pay for the next course of treatment.
So basically, if I understand you well, and I see Dr. Barnard has joined us, he's just setting himself up. Mediation, or the service provided by Dr. Barnard, actually provide us with a second opportunity, if I may say, to deal with the matter before it escalates to a legal process, which can be costly for both the practitioner and eventually maybe the patient.
Yeah, I think so too. And I mean, I think that one of the things that we're short of in dentistry in South Africa is the requirement to have a formal complaints process. And that's something that really needs to be promulgated by the HPCSA, this whole idea of having a complaints process. But, you know, patients want to, they want to have somebody who will listen to their concerns. And that's what Dr. Barnard does as the mediator. He listens to their concerns, then contacts the dentist and says, look, I've had this patient contact me. These are the things they're unhappy about. What do you say? And so we have a kind of process of negotiation until there's an outcome. And some it may not be the outcome the dentist wants, and it may be, it may just be a compromise. But if it's quite a serious complaint, then what Dr. Barnard may well do is he may well say to the dentist, look, maybe you should take some advice for your indemnifier. And that's where we get involved. Okay. We will look at the complaint and we will point out to the dentist, we will say, look, there is a vulnerability here, or you've nothing to worry about here, or we're happy with this bit. Go back to Dr. Barnard and here's what your negotiation point should be. And that's where we're involved in it. But we don't work with Dr. Barnard. We work separately with them. Yeah. We work only with the dentist.
I think at this stage, I'm going to welcome Dr. Barnard to carry on with his presentation. Dr. Barnard.
Thank you, Casey. So I'm not sure where I left you. I've been having problems with my internet all day, so I apologize.
It was the previous slide where you were explaining that the majority of the cases are non-clinical, and that was good news because it tells us that we haven't, the clinical side has not gone bad. And I think we may have just lost him once more. I really think he's having an issue tonight. Let's finish these questions. I will suggest if we really struggle, I might have to postpone this webinar so that we get him back online on a better day. But let's quickly answer the questions that I have. There was a question which I think you can deal with in broad terms, but it says, do dentists have rights or only patients according to DP?
Do dentists have rights? Only patients according to dental protection? No, dentists do have rights, because you'll see those rights enshrined in the duties of a patient in the ethical rules. So we're working for the dentist, but we recognize the areas where dentists create vulnerabilities. And there are patient rights, for example, the right to information to make an informed choice about your treatment. So there are basic rights, there are basic rights to healthcare, but dentists do have rights, and those rights are about the way that the patient interacts. So rights of the patient should be paying their account for treatment rendered, that sort of thing. But there are no health profession rights in statute. And I know that there was some work done pre-COVID in South Africa where there was a piece of work being done to create some constitutional rights for doctors and dentists, and I'm not sure where that piece of work has gone to. But we have to be very careful about creating rights for doctors and dentists.
And this questioner is, I think it's because of the SADA dental clinical protocol. Is it wrong to do root canal treatment without rubber dam in COVID-19? Is it ethical?
Is it unethical? I mean, I think it depends who you speak to here. I mean, clearly there will be occasions where you're carrying out an AGP at the moment and for whatever reason you can't fit a rubber dam around the tooth. But I mean, we get this rubber dam question all over the world because you either love rubber dam or you hate rubber dam. And the guys who use it swear by it, and the guys who don't use it say it never works in my hands. But right now, what SADA have said is that in the protocols, well, it's not what SADA have said, it's the protocols have said that when you're carrying out an AGP during COVID, you should use a rubber dam to cut down the aerosol that's generated. So is it wrong to do root canal treatment without rubber dam? Well, if we're trying to reduce an aerosol and the peer group is saying you must use rubber dam, then we're getting to the point where if you can't use it, there's got to be a very good reason why you can't use it.
Absolutely. I think going back to the issue of the patient, and I'm just going to deal with the questions that we have, and then we will decide to stop this, I think. I think it says the question from Dr. Osman, could we perhaps discuss some aspect of mediation and also how to engage with patient when a possible complaint is in the horizon? I don't want us to touch on that because if I remember, he touches on this in detail. So we're going to give him an opportunity to look at that. Let me go to the next question. This is off the topic. We answered this on Thursday, if I remember. Dr. Wardendal says, should oral hygienists employed by dentists have dental protection? Patients normally ask if practice has indemnified or indemnity for dentists and hygienists. I remember you dealing with this question, but it may be important for you to emphasize it tonight again.
Okay, so what we said on Thursday was that anybody carrying out clinical treatment should have indemnity or insurance in place. So the answer to this question, John, is should an oral hygienist employed by a dentist have dental protection? Yes, absolutely. I mean, we do indemnity for oral hygienists. So yes, if this oral hygienist works for you and doesn't have indemnity, then you've got a problem, because if the patient's damaged by the hygienist, then the patient's going to sue you as the employing dentist. And we spoke about this on Thursday, that your own indemnity with dental protection or with Aon or whoever it is with PPS will not extend to indemnify you from the acts and omissions of an employee.
Right. While Dr. Barnard is setting up, we're going to try this. Dr. Barnard will try it for the last time. If it cuts, I think the members will allow me, the audience, that we cancel this because they definitely want to hear from you, and then we will reset this for another day. In the meantime, while you're getting ready, Dr. Van Zyl says, a patient experienced a visit to a dentist who charged an additional 90 Rand for PPE, and the patient was not happy and felt that the dentist was just trying to make money. The patient asked if this was legal. I know that's not necessarily about...
okay, so the patient goes to the dentist, they're expected to be informed of the cost of their treatment, so a cost estimate should be provided. And I think nowadays, if you are adding on an additional 90 Rand for PPE, that's fine. I have no issue with that at all, because it's an extra cost that you need to build into your fees. Then you have to say to the patient, in order for us to comply with cross-infection protocols, standard operating procedures, then we've had to purchase more expensive PE for your safety and for our safety, and that cost is in the treatment. Or what you do is you put the cost of whatever treatment you're carrying out up by 90 Rand. So a filling that was 90 Rand becomes 180 Rand. But I think the key thing here is that we're in a completely new environment now where safety is the key. And the patients will have to pay for this increased PPE. It's just a fact.
Okay. Dr. Barnard, I think let's go to plan B that we agreed before. May I ask you to switch off your your video and now present on audio only. It might help your internet connectivity.
Casey, I completely changed the connection. So let's try it just once like this. Okay. And if it doesn't agree, we go to plan B. Okay, so again, apologies for the losing connection. I've struggled with my connection all day, and I sort of expected something like this, but I think we're connected now. Okay, so I'm not sure where I left you, but I promised you some good news. And the first bit of good news was that only 22.2% of complaints lodged to the Health Professional Council falls into a clinical category, which means 77.8% of the complaints is non-clinical. And this sort of agrees with my own findings as the dental mediator, where only 33% of complaints falls into the clinical category, which to me is good news, because it tells me that the rise in the number of complaints against dentists is not necessarily because we cannot do the work, but rather we fail to follow the rules of the game. And the recommendations coming from the study is that there should be an emphasis on ethics and practice management. So if you want to prevent patient complaints, you need to understand a little bit about the motivating factors behind patient complaints. I mean, what takes a patient from just being disappointed with you as a dentist and going to another dentist to actually lodging a formal complaint at SADA or the Health Professional Council? So there's several studies that shows that there are predisposing factors and precipitating factors involved in a patient's decision to take action. Predisposing factors is normally personal and relationship issues. So if a patient experiences rudeness from you, your team, or there's misunderstandings about the treatment or the cost of treatment, when patients experience a lack of empathy, arrogance, ignorance, or availability issues, while precipitating factors has got more to do with the clinical treatment or the outcome, the dry socket after an extraction, the pain after routine treatment, the file that separates in the canal, the sinus exposure or nerve injury after a difficult extraction, the failed implant. And I guess we could add to this a patient contracting COVID-19 at your practice. And the second bit of good news I have for you tonight is the studies clearly show that in the absence of predisposing factors, precipitating factors on its own is not enough to motivate the patient to formally complain. It's only when these two start overlapping, when you have a predisposing factor and a precipitating factor, that the patient is likely to complain. And again, this is good news, because in dentistry, we don't always have control over the precipitating factors. Dentistry is not always an easy profession, but we do have control over the predisposing factors. And a good example of this is this man here. Our friends from the UK will recognize Dr. Howard Frederick Shipman. He's a very popular GP from the Manchester area in the UK. He was well loved by his patients and their families, but he turned out to be one of the most prolific serial killers of all time, killing over 250 of his patients by injecting high doses of diamorphine, mostly elderly patients. His last victim was a lady called Kathleen Grundy. And if it wasn't for her daughter, Angela, who got suspicious after being excluded from her mum's will, while Dr. Shipman here inherited £386,000, then he probably would have killed many more patients. So Dr. Shipman was loved by his patients and their families. He was never arrogant, never rude, always on time, always available. No predisposing factors, many precipitating factors, no complaints. Okay, so by far the three most predisposing factors in my experience at SADA is miscommunication, rudeness, and money. Many international studies show that 70% of litigation is related to poor communication, where patients feel deserted, devalued, and ignored. People are also programmed to hear only the things they want to hear and ignore the things they don't. So if we communicate information about costs, complications, or risks, it'll take much more effort to get your point across. The second one is rudeness. You will find the word rudeness in every second letter of complaint from a patient and every response from a dentist. Some studies suggest that rudeness is behind up to 70% of complaints. So rudeness can contribute to complaints in two ways. The first of all is if we experience rudeness from patients. So the American Academy of Pediatrics published a study in 2015 that shows that our ability to perform diagnostic and procedural tasks can go down by as much as 12% if we experience rudeness from patients. It's very difficult to do good dentistry on a rude patient. The other way is, of course, if patients experience rudeness from us or from our team. Dentists often challenge me during mediation by asking, what's wrong with being rude? Surely it's not illegal. The thing with being rude is that you lose the patient's trust and the benefit of doubt in a profession where you often need it. For example, if the patient develops a dry socket after an extraction, if the dentist and his team was professional and gained the patient's trust through good communication, especially about the risks, the complications, and the costs involved, the patient would often blame himself for not keeping his mouth clean enough. However, if the patient experienced rudeness, a miscommunication, or misunderstandings about the cost of treatment, the patient would blame the dentist for an unhygienic equipment or technique. And the same goes for the failed implant or the other treatment that goes wrong. And the last one is money. 43% of the complaints received by SADA is because there's a misunderstanding about the cost of the treatment. Let that sink in. 43%, it's about half the complaints that we deal with. Misunderstandings about the cost of treatment is a very common and powerful predisposing factor. So what I want to do next is I want to show you through 8 recent case studies how dentists fail to do the basic things right and how these preventable situations lead to patient complaints and in the end contribute to the rising cost of indemnity. Right, so in this first case, a mum takes her 8-year-old daughter to the dentist for an examination. He took some x-rays and he diagnosed 5 cavities. He finished 2 restorations on the day and made another appointment to complete the other 3. It all went well until the mum received a medical aid statement showing that an amount of 6,000 Rand was claimed and that 9 teeth were treated and not the 5 agreed. So the mum contacted the SADA mediator. So closer investigation revealed that the dentist also did 4 preventative fillings and he charged 387 Rand 20 cents per filling, which was an additional 1,548 Rand that was never discussed or agreed. Now, so for some patients, this might not be a problem, but for a single mum raising 3 kids with a total medical savings account of 9,000 Rand, it is a huge problem. And despite explaining the advantages of a preventative filling to her, she still felt that if she was given the option, she would have declined. In this case, the dentist had to give back the money. Right, so let's show you another example. So in this case, Mr. J was referred by his dentist to the periodontist because he had a problem with his tongue. So during the consultation, it was agreed that a biopsy would be needed. But during the same consultation, Mr. J also inquired about a wart on his tongue. The periodontist gave an explanation which the patient understood and accepted. The periodontist quoted for his treatment, the patient accepted that, but he also gave a verbal indication of the cost for the histological examination of about 2,000 Rand. So the problem came when Mr. J received an outstanding account from the laboratory for 4,830 cents. And he refused to pay it because he said that Dr. A misled him about the cost of treatment. So the relationship broke down and the periodontist in this case contacted SADA to assist. So from Dr. A's side, he felt that he had a duty to send in all the tissue that he removed from the mouth in for histological examination, whilst Mr. J felt that if he knew the additional biopsy of the wart would be that expensive, then he wouldn't have proceeded with it. So after consulting with his indemnifier, Dr. A decided to contribute 2,000 Rand to the cost of the laboratory. So I listened, Alasdair said something about how mediation falls in with indemnity, and this is a good example because Dr. A consulted with Dental Protection and then came back to me with the decision to contribute 2,000 Rand towards the account for the laboratory. So we're functioning completely separately from each other. So why is it important to talk about the cost of treatment with your patient? Well, first of all, the National Health Act says that a user must be informed of the benefits, the risk, and the costs associated with each treatment option. The Consumer Protection Act says that a supplier must disclose the price of the goods and services. The Health Professional Council ethical rules says that a dentist shall provide adequate information about the costs, and the Health Professional Act says that a dentist shall inform the patient before rendering the service what fee he intends to charge. So we have an ethical, a legal, and a professional duty to make sure our patient knows the cost involved in our treatment. Traditionally, dentists in South Africa have performed poorly when it comes to financial consent and record keeping, despite a constant emphasis on the importance of it by indemnifiers and the regulator. You know, if you go in for a procedure, you want to know what your options are and what the costs involved. It's a basic information that you need to make the right decision for you, considering your circumstances. You know, what makes the retail sector slightly different than healthcare is in retail, patients can make informed decisions about their choices. They can choose whether they buy their food at Woolworths Food or at ShopRite. And then they can wander down the aisles for ages and compare different products and prices. They can see the product, they can taste it, they can smell it. And in healthcare, that's not always the case. I think as a profession, we need to work harder to make the decision process more translucent. So if we look at the key messages coming out of these first two cases, 43% of the complaints received by SADA is because of a misunderstanding about the cost of treatment or who would be responsible when there's medical aids or third parties involved. That's almost half the complaints. So if you want to effectively reduce your chances of receiving by, just make sure the patient understands the costs involved in your treatment. And it's as easy as making them sign a treatment estimate and keeping a copy in the records, because that's the first thing a third party will be interested in when there's a dispute about fees. The second one is that you need to be very careful when you communicate with medical aids on behalf of patients to establish benefits and obtain authorization, because you're arguably taking away the responsibility of fees from the patient. So if your receptionist phones a patient to inform them that their crown is authorized and the medical aid will pay, and the medical aid don't pay because the patient's wife has been to the optician for a new set of glasses, then you have a problem, because if the patient knew that he's going to have to swipe his ABSA credit card for his crown for 7,000 Rand, then he probably wouldn't have proceeded with treatment. The next one is that you need to include the future cost of treatment. So when you do immediate dentures, include the cost for relining the denture or replacing it later on. When you do a root canal treatment, warn the patient that a crown might be needed later on. And when you do orthodontic treatment, include the cost of the retainer phase so that there's no misunderstanding. The last one is whenever there's third parties involved, like dental laboratories, or just as we saw on this previous case, pathology laboratories, you need to make sure that you quote correctly and that the patient understands that you're quoting on behalf of a third party. The next one is that if the treatment estimate changed during treatment, that you need to sit down with your patient and discuss the changes. The consent is an ongoing process. It's not a once-off form that the patient sign. Post-COVID-19, I mean, the economy will take a long time to recover from this. And I think the financial consent process will now become more important than ever before, with a lot of people losing their jobs, others taking pay cuts. And then lastly, your staff communicating with patients about outstanding debt need to be very sensitive and well trained, because what we see at the Dental Association is that patients complain because of the quality of clinical treatment, because they cannot afford the outstanding account. So what would typically happen, you would send reminders at 30, 60, and 90 days, but the moment you hand over the account to the debt collector, then the patient complains about the clinical treatment. It's never been right. You still can't eat on the tooth. It's the wrong color. The food still gets stuck in between the teeth. So that's enough about the cost of treatment. I think you get the message there. So let's go to this next case. Okay, so in this case, a patient phones a practice to make an appointment to clean his teeth. He was quoted 280 Rand by the receptionist. On the day, there was a problem with the ultrasonic equipment and the dentist used hand scaling. The patient was not happy because his teeth didn't feel as clean as before. He reported that to reception, but he was dismissed and experienced some rudeness. He was, of course, not happy when he received his statement of 633 Rand and that saw that the dentist also claimed a full examination of his teeth. Again, he phoned the practice to try and complain. Again, he was dismissed by the receptionist. He phoned the SADA mediator, and through mediation, he was invited for a free appointment with the hygienist. The key message is that dentists often ignore complaints because they think the complaints has no merit. Our staff often don't inform us of complaints like this because they don't think it's important, or they're trying to protect the dentist. The problem is that it's exactly complaints like these that end up in front of the regulator. So if you or your staff choose not to deal with an issue, then you give up your right of control over the issue, and it will select the path of least resistance. Complaining to the Health Professional Council is easy and it's free. And once the Health Professional Council receive a complaint, it becomes a legal process, and you would need your indemnifier to respond to that complaint, which contribute to the rising cost of professional indemnity. These complaints can quite easily be prevented by having a practice complaints process in your practice. A lot of the work that me and my colleague, Dr. W.P. van Zyl, do at SADA is really what should be happening at practice level through a practice complaints process. I just remind you of some of your duties from the regulator, that from booklet 1, we have a duty to respond to criticism and complaints promptly and constructively, even if we think the complaints have no merit. From the Patient's Right Charter, everyone has the right to complain about healthcare services and to have those complaints investigated and to receive a full response on such an investigation. Right, let's look at the next case. So in this case, Mrs. N went to the dentist because she lost a filling on her upper left lateral incisor that she's had there since 2014, that's for 6 years. The dentist recommended a stronger option, Edelweiss veneer, and created the expectation that the restoration would last 10 years. She charged 2,730 Rands under code A355. Unfortunately, the restoration failed 2 months later. It was replaced free of charge, but failed again 1 month later. The patient was disappointed and demanded a full refund and said that she was being misled by the medical aid, by the dentist telling her that the medical aid would pay for the treatment. The dentist refused because she said the restoration fails because of the patient's bone eating habits. And also, she only provides a 3-month guarantee on restorations, which has expired. The patient disagreed and said that she only had rice and chicken stew for dinner, and the relationship broke down completely and the patient contacted SADA. The patient was even kind enough to send me some pictures of the chicken stew that she had for dinner and also a picture of the tooth. Now, if you look carefully at that picture on the left-hand side, you will see that there's quite a substantial amount of tooth structure missing on that lateral incisor, but there also is a lack of posterior support in the second quadrant. So I phoned the dentist to discuss the complaint, and the first thing I asked the dentist is, was the veneer the right treatment option here, considering that you knew the patient had a bone-eating habit and also that there is a lack of posterior support. And the dentist tells me what most dentists tells me in a situation like this is that it was a compromised treatment because there was no benefits or funds for a full coverage crown. So I asked the dentist, so what's the options here? Is ignoring this patient even an option? And we agreed that ignoring the patient is not an option. So we started generating solutions. So one possible solution was that a colleague in the practice replaced the veneer with a full coverage porcelain crown, and that the patient could pay only the difference of 4,769 Rand. Unfortunately, this option was not acceptable for the patient, and the patient still wanted a full refund. The dentist was not happy to give a refund because the dentist felt that she spent a lot of time treating her and that there was some substantial overhead costs. So we did a bit of maths. GEMS contributed 936 Rands for the treatment, so we divided the remaining 1,984 Rands by 2, and we rounded off to 1,000 Rand. Unfortunately, Mrs. N agreed for 1,000 Rand refund. So the key message here is that as dentists, we are often pushed into compromised treatment plans, either because the patient cannot afford the ideal treatment or because there's no medical aid benefits, or the right option is outside our ability or competency. Sometimes it's inconvenience for the patient to travel to see a specialist, and it's more expensive, so they put pressure on you to do the treatment. Sometimes the patient is scared where the right option is to remove the tooth, but they talk you into doing a root canal treatment because they're scared of the extraction. And it's exactly cases like these that will catch you from behind when your treatment fails. As dentists, we need to learn to say no and when to say no and take responsibility for our treatment decisions. Right, so if we go to the next case, I think we need to address the elephant in the room and say something about the COVID-19 pandemic. Now, relationships are often stressed by emotional, stressful events, and the dentist-patient relationship during this COVID-19 pandemic has proved no exception. What's uniquely stressful about the COVID-19 pandemic is that it's exacerbated by its duration and by that unknown quality. COVID-19 has, without doubt, posed the biggest challenge to the profession in my generation. And it's no surprise then that the COVID-19 pandemic and the associated lockdown regulations has led to an increase in patient complaints. Let me show you some examples. So in this case, Mrs. A contacts her regular dentist with a toothache. She's got some heat sensitivity, cold sensitivity, and spontaneous pain. The receptionist informed her that she couldn't have an appointment because of the level 5 lockdown restrictions, but she could have a telephonic consultation at 484 Rand. The patient was desperate. She agreed and paid, and the consultation was about 2 minutes, and the dentist advised her that nothing can be done and that she needs to go to hospital if the pain gets worse. Another one, Mr. X contacts his regular dentist with a broken front tooth in level 5 lockdown. The tooth is painful, too sensitive to heat, cold, and extremely sharp, and caused an ulcer on the patient's lip. The patient couldn't eat, speak, or breathe, and it was a huge aesthetic problem. The dentist refused to see him, and he said that it was not a dental emergency. So whilst telemedicine and working from home has worked really well for other professions and other sectors of the healthcare, like psychiatry, and will probably be the new normal for a long time to come, in dentistry, it's had its challenges. Most of the problems in dentistry requires a procedural approach, and the refusal to consult with patients in level 4 and 5 lockdown has led to a lot of frustration and an increase in patient complaints. You can imagine telling an established patient with an irreversible pulpitis or a patient that fractured his front tooth that he needs to take some Barnards will challenge any professional relationship, especially if another dentist is willing to see them. I've seen patients change dentists in the middle of a large prosthodontic or orthodontic treatment plan because their own dentist was not willing to see them during the lockdown. So let's look at another case. In this case, Mrs. H, who's a pensioner, contacted a regular dentist with a toothache. This was during level 4 lockdown. During the consultation, she was informed that there was an infection in her lower left first molar. The tooth was cracked, and she was referred to a maxillofacial surgeon to remove the tooth. Discovery paid 280 Rand 60 cents of the total of 1,193 Rand that was claimed. So 905 Rand was not covered because of the cost of PPE, and the dentist charged an after-hour visit despite seeing the patient in the middle of the day. So despite this pensioner earning about 10,000 Rand, having a medical aid, she still had to pay 905 Rand for a prescription. She still has to buy the medication. Now, a few weeks ago, I think a very few people in the world knew what the abbreviation PPE stands for. Well, by now, the whole world probably knows what it stands for, and it's caused a lot of frustration and headaches for patients and dentists, and led to a lot of patient complaints. You know, as dentists, we're not supposed to work without it, but it's expensive, it's not always available, and we don't know how to charge for it because the medical aids don't pay for it. You know, some dentists charge between 50 and 400 Rands for PPE, and patients don't like that because their medical aid don't pay for it. Patients are also not stupid, they phone around, and if one dentist charge 50 Rand and another dentist charge 400 Rand, it could quite easily lead to a breakdown in relationship and a loss of trust. The other problem with PPE is that it severely impacts our ability to communicate with our patients. We learned earlier in this presentation that 70% of litigation is related to poor communication. We also know from literature that 80% of communication is nonverbal. So you try and speak to this gentleman on the picture here about your fears, your expectations, your concerns, and your questions. There's no friendly smile, there's no warm handshake, there's very limited eye contact. This can quite easily lead to an increase in anxiety and an increased risk for getting a patient complaint. So let's look at another one. So a mum takes her 15-year-old daughter to the orthodontist. This was in the beginning of this year. The mum accepted the treatment plan and the quote and agreed to pay in installments. But during COVID-19, unfortunately, she lost her job. She couldn't afford the monthly installments anymore. She contacted the dentist and asked the orthodontist and asked if she could pay 100 Rand a month until she could find a new job. Unfortunately, and very rightly, the orthodontist refused and said that the braces needs removal. You know, the economy will take a long time to recover from this COVID-19 pandemic, and I predict many more complaints like this to come. The financial consent process will now be more important than ever before, with a lot of tough ethical questions to come. You know, although the COVID-19 pandemic has posed some new, unique challenges to the profession, the principles of preventing and resolving disputes remain the same than before. The three main predisposing factors, miscommunication, rudeness, and misunderstandings about the cost of treatment, are still behind most patient complaints. And as dentists, we need to use our common sense and communicate with patients information about current regulations and restrictions, and the cost of treatment, especially PPE. And we need to do that in an empathic way and explain to the patients why it's in their best interest to do things the way we do. And through good communication, most of these complaints can be prevented. So I'm nearing the end of my presentation, and I just want to highlight the most important aspects. The first bit of good news I gave you is that 77.8% of complaints are categorized as non-clinical. The next one is that most of these complaints are preventable by doing the basics right, by making sure we know the rules of our profession and adhering to them, but understanding the role of predisposing factors in the patient's complaints, by implementing a practice complaints procedure at your practice, by making sure the patient is aware of the cost of their treatment, and by not being bullied into compromised treatment plans. And by making sure we keep good records. And that's it, Casey. That's my presentation for tonight.
Thank you very much, Dr. Barnard. I'm glad that we finally got through this without major hassles. We have, at the moment, a few have left us. We were 584 at one stage, we've got 578. I want to say thank you to Alasdair. He's been whittling away the questions on the Q&A section. So if you have not received the prompt and you're an attendee and you have asked a question, on the Q&A section, you will see the answered questions. If you click on that, you will see all the questions with answers. We're trying to ensure that we move a little bit faster. So if you check on the Q&A, that section. So what I will do is we've got 4 questions that are not yet answered. I am going to ask what the first question, because we've answered it, but I think it might be good that you repeat that. Dr. Kobus, Barnard, how do patients of the various dentists get to, how do their cases actually get to you? What is that process? Because some people don't seem to understand.
Okay, thank you, Casey. So when a patient is disappointed with his dental treatment, he only has a few different options. Okay, one option is to leave the practice and find another dentist. One option is to contact the regulator, the Health Professional Council, and formally complain. And one option is to contact the South African Dental Association. And one option is to go and see a lawyer. So when patients contact the South African Dental Association, all those complaints are referred to myself and Dr. Veerpeer van Zyl, who runs the mediation service on behalf of SADA. So that's how the complaints end up in front of on my desk. The other way complaints end up on my desk is if dentists or members of SADA, specialists, ask some assistance in resolving patient complaints. Some of them are referred by the indemnifier, or some of them don't have professional indemnity and asks the assistance of the mediator to try and find an outcome without the need for getting lawyers or third parties involved.
I think what I want to add on that is for the members to know that when the patient, when they contact us, basically they either send an email, that email goes directly to the mediator. It does not go anywhere. My staff don't get to see it. Sometimes they make a telephone call to the office, and then they are then directed to Dr. Barnard's office. That's how it works. We do not keep any details of the particular patients. And then the case is dealt with through our mediator. There's no interference whatsoever from the office or from dental protection. What I also wanted to answer part of that question is that the HPCSA is aware of the process that we have set, which is the mediator services, and they actually support us wholeheartedly. They believe that the oral health has done a great job because other sectors have not done so. In actual fact, to a level that the Medical Association of South Africa have actually, or the South African Medical Association have actually asked SADA through Dr. Barnard to come and explain to them how the process works, because they want to implement the same thing. The Ombudsman has actually said to us that had it not been for this process, the HPCSA would have a backlog that they would never be able to finish. So they really appreciate. I think hearing from DP itself is that we are able to deal with the issues before they escalate to a level where you have to pay a lot of money. So I think it's a beautiful and a wonderful service that we have.
It's a free service for everybody, Casey, and you don't have to be a member of SADA. You don't have to be a member of Dental Protection. It's a service that's open to patients and all dentists. What I would say is that don't get confused with the mediation that goes on within the HPCSA. So the Ombudsman, the HPCSA Ombudsman also does some mediation of low-level complaints. And we can't control where a patient goes to complain. If they go to the HPCSA, generally the complaints that the Ombudsman will try and mediate are about fee disputes. So low-level stuff. And if the HPCSA mediation process fails to achieve an outcome, the matter has to be referred on to the Committee of Preliminary Inquiry.
Yeah. The question that's on the system, Dr. Kisun says, are we at liberty to actually provide a guarantee for professional services rendered to patients, bearing in mind the variation in the dynamics of the oral cavity? I don't know who want to take that.
Okay, so I mean, this is quite a complicated question to answer in a couple of minutes here. I think that if we spoke to most of the guys on the call here, they would be prepared to guarantee the standard of their treatment for a certain length of time. And I think the guys who do the implants provide a guarantee that if the implant fails within a period of time, they will replace that implant. But I think that the clinicians are more likely to tell me what they would do there. So looking at the question, are we at liberty? And I had to give guarantees, and I think, why not? If your treatment's good enough, then tell the patients that you offer a guarantee.
Thank you. The next question says, can we refuse to do endo treatment on an uncooperative 12-year-old child, even if the mother pressurizes you to do it? You know the treatment will fail. Yeah, you know the treatment will fail. What do you do?
Well, I'm looking for this question.
Should I read it for you?
Do endo treatment on an uncooperative 12-year-old child, even if the mother pressure, you know that treatment will fail. What do you do? Well, I mean, the child needs to be cooperative before you can carry out the endodontic treatment. So, there are a number of options that you need to think of there. Are you providing treatment against the will of the patient? And I think that it's very clearly not in the interest to force a patient to have treatment, even though they're 12 years old. I think that would be the first thing that I would say. And I think that, how you manage an uncooperative child and get them to become cooperative. I mean, it's the easiest thing in the world is to take them to theatre and do a GA. Then you get full cooperation, but that brings risks that don't exist in the dental practice that people would prefer to avoid. And it's about a conversation. And then there may be somebody that you can refer this patient to, maybe somebody who's a specialist in pediatric dentistry, or there's somebody local who you know is really good at managing anxious or difficult child patients. But I'm not sure that there's one straight answer to that question. But I know myself, if I was forced with carrying out an endodontic treatment in a non-cooperative patient, you cannot carry out that sort of treatment unless you have cooperation.
Thank you so much. The other one is, if parents are divorced and the mother brings the child for treatment, but it is the father's medical aid that would be used, which parent financial consent do we need to get? Is it that of the father or that of the mother? So the medical aid, the medical aid is that of the father. The parents are divorced. The person who brings the child to the practice is the mother. Whose consent should we get?
Simple answer here is somebody with parental responsibility, so it's the mother.
Thank you so much.
And then they need to sort out the problem, the domestic problem.
Thank you. I think this will be an easier answer for you, Alasdair. Typically, who pays for the oral hygienist dental protection, the dentist or the hygienist?
I mean, listen, my view on this is that the oral hygienist should be paying for this, but it needs to be built into some sort of contract that they have and deciding who's paying for it. But, you know, I think as professional people, I think that we're all registered healthcare providers. I think that we have to take responsibility for our own indemnity. If you've got an employer who's prepared to pay, that's fine.
Thank you. Just at this stage, we should be closing the meeting, but please allow me to take for another 7 minutes or so, just because we had those hiccups, just to deal with some key questions, if you don't mind. There's a webinar request on non-clinical cases, issues summarized or listed to bring to our notice what's commonly neglected and solutions. So basically is that maybe we should have another webinar that can summarize non-clinical cases, issues, be listed so that it can be brought to the members' attention to see what kind of things they must deal with in future. And I think Dr. Barnard can look at that.
Casey, can we take the next question down about the rubber dam, because this is...
Yes, I'm going to that question. You've read it already, just for the purpose of the attendees. To Dr. McKelvie, this does not answer my question. Will the EOS be acceptable instead of rubber dam using COVID-19 in case of an issue arising with a patient who claims that you, the dentist, were the vector of transmission, as you did not use rubber dam, but you as a dentist have instead used an EOS?
I mean, the answer to this question is that the closer that you can comply with the SADA protocols, then the easier it is to defend you here. So, you know, the issue of a defense depends on a number of different factors. And, you know, you're asking me, will the EOS be acceptable instead of rubber dam used during COVID-19? And that's an answer that you need to get from the guys who put together the protocols, what they think. Our job is to defend you. It makes it a lot easier to defend you if somebody accuses you of transmission of virus if you've been using a rubber dam. But as I said to the Mr. Anonymous here, is that, you know, if you don't use a rubber dam, then you leave yourself open to criticism here. But, you know, we're not saying to our members, we will not indemnify you if you don't use rubber dam. What we're saying is the further you are away from following the clinical protocols, then it gets a lot harder for us to defend you.
Thank you. This one is to me. Casey, are you saying that if a complaint goes to the HPCSA, they are referring to the mediator? Dr. Barnard, I think it is, said that all cases have to go for investigation. Can this not be the process first to mediation rather than HPCSA first? Alasdair, do you want to deal with this or must I deal with it?
Are you saying if a complaint they are referring to? Okay, so if a patient complains to the HPCSA, the HPCSA by law have to investigate the complaint. Okay, what they will do is they'll do an initial screening of the complaint and they'll read what the complaint's all about. And if it's about an issue about I wasn't told about the cost of this treatment, then what they'll do is the matter will be considered by the Office of the Ombudsman. And the Ombudsman will try and mediate a solution. Or if the patient's saying I wanted my money back and I didn't get it, or I was overcharged, normally those things where there's not a complaint about the quality of treatment can be managed by Dr. Quinda's office, the Office of the Ombudsman.
Thank you. So maybe to answer part 2 of that question, yes, if I understand your question, is that we would love that the mediation be the first point of contact, because that way we avoid all the unnecessary, yes, Alasdair?
Yeah, no, I mean, what I'm saying is that there's a screening done, and what we find is that the complaints about fees, and it's only about the fees, may be considered for mediation, but
yes, yes,
a complaint about treatment or the behavior or the conduct of the dentist, it goes straight to the prelim committee.
Yes, yes, agreed, agreed. Should we get patient to sign a disclaimer about risks of contracting COVID treatment during this pandemic?
Okay, Dr. Rosini, we discussed this at length last Tuesday, and it's probably a good idea if you go onto the SADA YouTube platform, and you'll find the whole lecture there, and you can sit down and relive the glory of the whole webinar and find out what we said. But we said that there's a number of different reasons why we don't want to use disclaimers. And the main one is that you cannot contract out of your duty of care, and nor can a patient consent to negligence. So they're not worth the paper that they're written on.
Okay, this one is an important one. A colleague filed 236 without local anesthetic. Patient came to me with severe pain and complaints. The radiograph showed a dental abscess. The filing just covered the caries. The colleague does not own an X-ray machine, but has more than one practice. What is my responsibility to my colleague?
I'm just reading the question carefully, Casey. Okay, so you've got a dentist who does not have X-ray facilities, and that would cause the HPCSA some concern, I think. I think the practice of dentistry requires, I think there's an expectation by patients that they would obtain a reasonable standard of care from every dentist in the country, and the reasonable standard of care would include the ability to carry out investigations involving the exposure of X-rays.
All right. This one, a long question, but I'm going to try and read. It says, I had a patient who was booked for an appointment for a consultation. However, this patient expected that a cleaning and 2 restoration be done at the same visit. The patient was rude, arrogant, and not understanding from the outset. First-time patient. The patient said that he expected good service and wanted all treatment to be done at a single visit, despite me explaining the issue of time constraints and that of needing to follow our practice protocol for COVID situation. What are our rights in cases like this? As this patient was very demanding, am I allowed to refuse to see such a patient?
Kobus, you can pick this up. This is right up your street of managing patients and dealing with challenging patients.
Yeah, thanks, Alasdair. Yeah, I talked about rudeness in my presentation, and this is a very good example of it. You'll see the word rudeness there in the dentist response, and like I said, it is a very strong predisposing factor, because the moment we experience rudeness from a patient, it affects our clinical ability. And as highlighted in that study, your ability to perform a diagnostic and procedural task will go down by 12% immediately. It's just difficult to do good dentistry on a rude patient. But I guess that's part of being a professional person, is being aware of your emotions and through good communication, win the patient's trust and explain to them why you do things the way you do, and why it is in their best interest to do things the way you do.
So the other thing I would say is, I mean, these situations are really, really difficult because none of us are trained I mean, it's hard enough right now doing dentistry with extra PPE, and then you've got patients with unrealistic expectations. So the answer is, am I allowed to refuse to see such a patient? Yes, as long as they've not got a dental emergency. But, you know, I think you've got to explain why it's not a good idea for this relationship to continue. And I think that you've got to also look at why the patient had an expectation that everything would have been done. And, you know, good communication starts at the very first contact with the practice. And I think that we're seeing more and more of this stuff happen where patients are demanding, behaving like consumers. And I think that we've got to be aware of this. And when the first contact takes place between the patient and the practice, your reception team, your practice managers have got to be able to manage that patient's expectations and say what the appointment's for and what the limits are and what be provided.
Okay, the next question, and we are now at 20 past, so I'm just going to take 2-3 more questions. We are done. So this one we're done with. I note with concern that patients have constitutional right to emergency care despite bad debts or outstanding account. Where is the regard for the dentist and his her expenses and or trust for that matter?
I mean, I've already answered this question during the lecture, and I said that, you know, it's a good idea to find out why the patient hasn't paid for the treatment. But there is this constitutional right and legal statute that says you cannot refuse somebody who's got a medical emergency.
Thank you so much. I'm going to take 2 more questions, and I see there's a follow-up on that rubber dam issue. I'm going to take this one from the 2 questions, one from Dr. Sultan and Dr. Fori. How should one manage a patient that refuses to pay the PPE and says they don't think the use of PPE is necessary? And I think you kind of touched on that already, Alasdair.
Yeah, you've just got to be, I mean, you've just got to make sure patients understand. I mean, from what I'm hearing is that majority of patients are very understanding of the challenges. I mean, you only have to speak to your medical colleagues to find out how dreadful this disease is when people contract it and what a dreadful death it is. We are, as dentists, trying to play our part to reduce transmission. And the dental practice is a very dangerous place for dentists, their staff and patients to be in because of the aerosols that are created. So that if the patient's not prepared to pay for the PPE, then I wouldn't see them.
Yeah. Okay, the next question, and which will be my last question, should a hygienist be able to charge code 8101 or 8104 during a routine clean and decide to take pens or any other x-rays without dentist being consulted?
Kobus, you pick up the codes here.
Okay, so code 8101 is for a full examination. Code 8104 is for a limited dental examination. Yes, so the question is, should a hygienist be able to do a full dental examination of all the teeth and the periodontal issue?
No, I can't see how the hygienist could, because a full dental exam is not within their scope of practice. So that would be the first thing I'd make. They can carry out an examination of a periodontal condition and the other things that are within their scope of practice, but I don't see how they can carry out an 8101, and presumably that's a code for a dentist to claim.
The last question that I'm going to take is from Dr. Napier. We know the use of pre-treatment mouth rinse and gargle leaves the oral cavity significantly COVID-free for 15 minutes. Does this not negate the need for a rubber dam if it's difficult to place it if the AGP is less than 15 minutes? And I think this is an important one to deal with. That's why I'm choosing this, because we have dealt with the issue of this pre-treatment before. Alasdair, do you want to take this one?
I mean, I'm not aware of any evidence, because this would be a solution worldwide that would be welcomed by dentists. So if Sean's got the evidence to back that this reduces the virus to a level that is quite safe, then I'm shocked and I'm surprised, because the rest of the world the rest of the dental professions around the world are looking for the similar solutions. How can we reduce of a virus in the aerosol? And he may have evidence, but I'm not sure where that evidence is. And I think that what he should be doing is he should be giving that evidence to the guys who put the protocols together to see if there's something they can revise, because I know it's a live document.
Thank you. In general, as I finish, we actually have released a statement about someone that went around claiming that if you use this pre-treatment and a mix of various mouth goggles, this can happen. And we said it was not coming from SADA. So please just be aware and be careful. Dr. Napier, you've got my details. You should have our details at SADA if you want to maybe engage with us and DP, so that maybe we are aware where the evidence that have led you to say that statement comes from, so that we can learn. The last general statement is that if you see, because I see quite a few questions on this, like from Dr. Chetty, if there is a practitioner, an oral health practitioner that is doing something out of scope, your responsibility is to make the relevant authorities aware. And your first relevant port of call is to report that particular person or persons to the HPCSA and let them do the job. That's the statement I want to make in general. I want to say thank you to Dr. Kobus. I want to thank you to Dr. McKelvie for being here tonight and being with many of us. And I want to thank all of you that attended this session. And I can see Dr. Barnard, there's quite a few, I didn't read them one by one, but quite a few of the members that have been saying, thank you so much for such an informative session. It was really things that sometimes we ignore and only concentrate on clinical stuff, but things are going wrong on the other side. So thank you for this, they say. And I want to say thank you to everyone and have a good night.
Good night.
Good night. Thanks, Casey.
By the way, for those as you are